Good morning. Welcome to another session of short course in clinical epidemiology. Today we'll use a checklist called the tripod checklist. We have done one tripod checklist previously, but this is a new update with the 2025 version. But there is also some guidelines on tripod AI, but we thought we'll do this tripod 2025 checklist now and have the AI addition in the future sessions that we'll be having in the next few weeks or so. So today I'm pleased to welcome Dr. Andrew, who has taken a similar study to use the tripod checklist and appraise using the tripod checklist. And I'll hand over to Dr. Andrew for this session.
Good morning, everyone. So today we'll be looking at using the tripod checklist. Really appraise a stratification model that is used to predict the risk of Barrett's esophagus progressing to carcinoma. So we start with the clinical scenario. So we'll start with the clinical scenario. Let's take a gentleman, Mr. A, 55-year-old gentleman who comes to your OPD with risk factors of smoking and obesity. And he also complains of reflux symptoms for the last 5 years. So you advise him to do an endoscopy, and his gastroscopy results shows Barrett's esophagus about 3 centimeters segment, and you start him on oral PPIs. You also explain to him that Barrett's esophagus is a pre-malignant condition, and there's a risk of progression to adenocarcinoma. And you tell him that he needs to undergo gastroscopy every 3 years. However, the patient tells you that his last endoscopy was very uncomfortable, and he is not willing to repeat the procedure. So our question is there an alternative for patients with Barrett's? Is there an alternative to screening them with endoscopy every 3 years? Is there any other way of detecting their progression to carcinoma? So to answer this question, we'll be looking at this study. This is a cohort study done in the UK, which is evaluating a new capsule-based endoscopy test. This capsule-based endoscopy test also identifies a few biomarkers within the cells. And overall, it gives a prediction as to whether the patients are at a low risk or at a high risk of progression. And this is a prospective evaluation of a real-world implementation of the test. Now, as you know, for any risk stratification test, there has to be one study for the development of the test and one study for the deployment and evaluation. So the development of this test was done in 2017. That is called the BEST-3 trial. That was published in 2017. Following that, this study was deployed in the UK, and then this is a prospective evaluation of how that tool performs in the real world. So to answer this, we will be using the tripod checklist today, and we'll go through each of these categories in detail. First question regarding the title. So the title should identify the study as evaluating either developing or evaluating the performance of a prediction model. It should identify the target population and what's the outcome to be predicted. So this title is clearly specified that it's a biomarker risk stratification tool. The population is adults with non-dysplastic Barrett's based on the last endoscopy test done. The intervention or the predictor that is used here is a capsule-based endoscopy test, which also includes histopathology and biomarkers, which then we use those markers to predict as to whether the patients are low, intermediate, or high risk groups. The comparison is with intergroup comparison between the low, moderate, and high risk groups, whether the stratification actually works and are the low risk groups at a lower risk of progression as compared to the high risk groups. The outcome we are looking at is the diagnosis of high-grade dysplasia or cancer. The outcome is diagnosed based on a formal endoscopy. And the time period of the study was from August 2020 to December 2024. So the background of the study is that Barrett's esophagus is a pre-malignant condition where there is intestinal columnar metaplasia of the normally squamous mucosa of the distal esophagus. Now the progression, normally there is, so in Barrett's esophagus, there is only normal columnar metaplasia. That normal columnar metaplasia may eventually progress to dysplasia, which may be indefinite, low grade, high grade, and high grade dysplasia may eventually progress to esophageal adenocarcinoma. So that is the usual progression. But however, it is not a very high-risk pre-malignant condition. Overall, in their lifetime, less than 5% of patients with Barrett's will actually develop esophageal adenocarcinoma. And the annual risk of progression is only 0.1 to 0.5%. Now, the current guidelines state that patients with Barrett's esophagus require endoscopies, serial endoscopies for follow-up. So if at the beginning there is no dysplasia, then you follow them up every 3 years with a repeat endoscopy. If there is dysplasia, but it's not able to be categorized as low-grade, high-grade, we call that indefinite, and these patients will have once a year scopies. If there is a low-grade dysplasia, then they need endoscopic resection, cryotherapy, or radiofrequency ablation of the dysplastic area. That will be followed by repeat endoscopy every 2 years. And if there is high-grade dysplasia, again, they require endoscopic resection. This will be followed by repeat endoscopies every year. Now, this is the current recommendation, but does this screening actually improve mortality? Do we actually pick up carcinoma earlier by doing this 3-yearly screening? So to answer this question, there is a trial called the BOSS trial, Barrett's esophagus surveillance versus endoscopy at need study. This was done in the UK in 2019. So in this trial, they looked at patients with Barrett's esophagus without dysplasia. They randomized them into 2 groups. One group, the control group, got the guideline-based screening every 3 years. The intervention group got only on-demand endoscopy, meaning if the patient had worsening of the GERD symptoms, then they would have an endoscopy. But otherwise, they were not given 3-yearly endoscopies. And the outcome they looked at was overall survival. They had a median follow-up of 15 years. The results of this study were that they randomized 733 patients to the surveillance group and 1,719 patients to the intervention group. The median follow-up was 12.8 years. And at the end of the follow-up period, there was no difference in overall survival between the intervention and the control group, with a hazard ratio of 0.5. So the conclusion of the study was that screening does not really improve mortality outcomes in these patients. And at-need endoscopy was a reasonable alternative to doing every 3-yearly endoscopies. So the aim of this particular study is to see whether we can reduce the burden of endoscopy, repeat endoscopies on these patients, and to prospectively evaluate a capsule-based endoscopy-based risk stratification tool to see if this can identify patients with Barrett's who are at a high risk of progression. And those high-risk patients, we can do repeat endoscopies. The low-risk group patients, we can either do at-need endoscopies or we can follow them up with a capsule-based endoscopy. So that is the main aim of this study. So describe the healthcare context in which the study was done and the rationale for developing prediction model. So this is designed to be used in a secondary or tertiary healthcare setting, which already has endoscopic equipment. The advantage of the capsule endoscopy is that it can be done by a nurse or a trained technician. It basically involves a capsule with a sponge at the end that you swallow. And about 10 minutes later, that capsule is pulled out through the mouth again, and then the capsule is washed, and cells from the cells that are collected by the sponge are then centrifuged and then analyzed. So this takes only about 5 minutes. It is easier to do, less invasive for patients, and it can be done in a secondary or a primary setting also. There are no similar pre-existing models that have looked at stratification of patients with Barrett's esophagus. So to describe the target population and the intended purpose of the prediction model, the target population was adults over 18 years living in England, Scotland, and Wales who have been diagnosed with Barrett's based on a previous endoscopy. The capsule endoscopy test is intended to be used to screen and stratify patients into low and high risk groups, and it's designed to reduce the number of endoscopies being performed. Now, in UK, another problem they had when they were shared that when primary physicians are scheduling patients for a endoscopy, the waiting time, average waiting time was between 6 months to almost 1 year. So another goal of this test was to reduce the burden of endoscopies on the healthcare system, hopefully to identify only those at high risk, and those high risk patients can then be prioritized for endoscopies. The study objectives was to prospectively evaluate the real-world performance of the capsule endoscopy risk stratification tool, which was previously developed based on the BEST-3 trial, to identify those at highest risk and prioritize them for early endoscopies. And in patients who were at low risk, we can reduce the number of screening endoscopies in these patients. To the methods that they used, this was a prospective multi-centric cohort study. The study was done in 13 centers, 13 tertiary hospitals in the UK. Participants were recruited from August 2022 to December 2024. Now, some stratification models use synthetic data. If they're using an AI model, they may generate synthetic data. So that part of the questionnaire also you have to mention whether any synthetic data was used. This was a prospective trial in which patients were recruited going forward. So there was no synthetic data that was used in this trial. Now, the study authors have said the study was conducted between August 2022 to December 2024. They have not mentioned exactly when the last patient was recruited during this 4-year time period. The follow-up period also, they have not given a definite follow-up period. The follow-up period is, so the protocol is that these patients have a capsule endoscopy done, then they are scheduled for a formal endoscopy. So these patients are followed up till the formal endoscopy is done. That formal endoscopy time depends on the waiting lists and the patient's physician. So some patients actually had a waiting period of up to 2 years till they got a formal endoscopy to confirm the results of the capsule endoscopy. So that was a limitation of the study. And so because of that, we don't have a specific follow-up period. But they have said that for some low-risk patients, the endoscopy was done only 2 years later. So I'm assuming the last patient would have been recruited in December 2022, because it would not have been possible to recruit patients after that. The methods they used for the participants, they had recruited 30 patients from 13 tertiary hospitals in England and Northern Ireland. The previous S3 trial was also done in England and Northern Ireland. Normally, the validation of the stratification tool should be done in a different population, but this was done in the same population. It was done in different hospitals, but the population was the same population in England and Northern Ireland. The inclusion criteria they had looked at was patients above 18 years of age who had a diagnosis of non-dysplastic Barrett's at their last endoscopy. The exclusion criteria was if they already had high-grade dysplasia, they were excluded. If they had any previous endoscopy for surgical intervention therapy, that was also an exclusion. Lastly, if they had any contraindication for capsule endoscopy. Generally, the contraindications for a capsule endoscopy include patients who have dysphagia, esophageal motility disorders, if they have esophageal strictures, webs, or an MI in the last 3 months, or any previous esophageal surgery. There was not an extensive list of exclusion criteria, and all these exclusion criteria are logical and acceptable reasons to not do a capsule endoscopy in a patient. So the details of treatments received and how the treatment varied through the follow-up of these patients. Now, after this capsule endoscopy was done, patients were stratified into low and high risk groups, and these had to be confirmed with a regular endoscopy. So when the capsule endoscopy was done, the patient's primary care physician was informed about the results of that capsule endoscopy. The physician was informed that they fell into either a low risk group or a high risk group. So during this waiting period for a regular endoscopy, it's possible that these patients would have been started on PPIs or specific treatment for, if the physician was apprised that the patient was at high risk, very likely that they would have started specific treatment, advised lifestyle modification for this patient. So that is a limitation of the study, because the confirmatory endoscopy was done almost 2 years later for some patients, and during that time, the treatment would have been different because the physicians were appraised of the results. So the methodology of this capsule endoscopy is that it consists of a sponge at the end with a string attached. The patient swallows the capsule. Once it enters the stomach, there is an outer shell which breaks off, and then the capsule expands. This expanded capsule is then pulled back, and as it passes through the lower esophageal sphincter, it threads off the cells of the epithelium, which is then withdrawn through the mouth. These withdrawn cells are then washed from the sponge, then centrifuged, and the Strident block is prepared from these cells. Now, if you look at the second half of the picture, there are 3 clinical domains based on which the risk stratification model works. One is the clinical factors, which is age, sex of the patient. Male patients were considered a higher risk. And the length of the Barrett's segment. More than 3 centimeters was considered a high risk for dysplasia, less than 3 was considered low risk. So those are the clinical risk factors. Then based on the capsule endoscopy, hematoxylin eosinophil staining, and whether the presence of the P53 biomarker in the cells, these were the clinical biomarkers and the histopathological biomarkers. So based on these 3 domains, patients were classified into either low, moderate, or high risk groups. Now, in addition, so this is the algorithm they have followed. So based on the capsule sponge test, if the biomarker is negative and the patient has no clinical risk factors, they're considered low risk. If biomarker is negative, but the patient has clinical risk factors, which is a Barrett's length of more than 5, or if they're male patients with an age of more than 60, or if there's an increase in the circumferential length, they will consider a moderate risk. And if patients had biomarker positive, they automatically go into the high risk. Now, within the high risk groups, if they had other histopathological features, like in addition to P53, there were other biomarkers positive, or if they had any other risk factors, they were considered within high risk, they were stratified into high risk tier 1 and tier 2. So this is the algorithm they have followed for this particular test. Now, in a risk stratification model, we also have to see whether they have stratified the data across socioeconomic groups and whether they have used any data cleaning methods. This is particularly applicable when you're using a stratification model based on retrospective data, or you're using data from some particular database, then you have to clean the data, see where the original data is collected from. That is not applicable in our study because this is a prospective evaluation. The outcomes they have looked at, the primary outcome was a diagnosis of high-grade dysplasia or cancer. Secondary, so the primary outcome was diagnosis of high-grade dysplasia. The secondary outcome was a diagnosis of any dysplasia, whether that's low-grade or high-grade. So now this test is intended to be used as a screening tool prior to doing an endoscopy. So we are primarily interested in the negative predictive value of this test because it's intended to be used as a screening tool. And we are also interested, so particularly we are interested in patients who are stratified as low risk. In those patients, what is the risk of developing a high-grade dysplasia, or what is the risk of developing any dysplasia in the low-risk patients? Now, the outcome assessment was done by a pathologist. Now, ideally, the study author should have described who were the outcome assessors, what are the qualifications, were they experienced enough to assess the outcome. They have only mentioned that the outcome assessment done by a pathologist. They have not given us the qualification details of the outcome assessors. Now, the pathologist who's analyzing the slides, they were blinded to the previous biopsy reports. If they had a previous endoscopy or the previous capsule, they were not informed of the report, so that they could independently analyze the slides in the block. So as we said, the three domains I looked at was the clinical domain, histopathological domain, and the biomarker domain. Clinical domains were age, male gender, and length of the segment. Histopathological domain was the presence of cellular atypia. And the biomarker domain looked at was P53 positivity. Now, one limitation here is that when you're doing an endoscopy, you can look at it takes a piece of the lower esophageal segment. So the pathologist is able to tell you the cellular architecture, whether there is invasion, length of invasion. Now, here in a capsule-based endoscopy, you are only withdrawing the surface epithelial cells, which are then centrifuged. So it's practically like a psychological test. So the pathologist can only tell you, based on the individual cells, is there any nuclear atypia, cellular atypia. They cannot tell you depth of invasion. They cannot look at other features based on this tool. So that is one significant limitation of the capsule endoscopy. Now, when these patients were recruited in the study, all the clinical predictors which we talked about were assessed at the baseline. There was no blinding of the predictors. The endoscopist was informed that these patients had a high risk. The endoscopist was informed about any previous endoscopy result. Now, this was done to mimic a real-world situation because an endoscopy is not a it's so the endoscopy test is actually a little operator dependent. So it's important that the person doing the endoscopy should know that this patient had a previous Barrett's esophagus with a certain length. So they will take adequate biopsies from the whole segment. So I don't think this was a significant limitation of the study. Now, if the predictor measurement requires subjective interpretation, again, for the predictor assessors, in the person doing the capsule endoscopy, what is their qualifications? Again, that information is not provided. We are only told that some group of technicians were trained in the capsule endoscopy. They were appointed at each hospital and they performed the capsule endoscopy. Coming to the sample size calculation, now based on the previous BEST-3 trial, they have assumed that the prevalence of dysplasia in patients with Barrett's is less than 6%. So that prevalence with a power of 80% and a one-third alpha of 0.05, they calculated that 440 patients would be required in the low-risk. They've also given us the other calculations for different power levels, what would be the appropriate sample size. So for a prevalence for any dysplasia, low-grade or high-grade less than 6, they would require a sample size of 440 for a power of 80. If they're looking at only high-grade dysplasia, which has a prevalence of less than 3%, then with a power of 99, again, they would require the same sample size. So finally, they've taken the second column, which is a sample size of 489, which with a power of 84% should add a prevalence of less than 6% dysplasia. Now, the analytical methods used in the study. Now, this part of the tripod question usually deals with when you're using a stratification tool based on pre-existing data sets, like you're looking at the demographics. If you're looking at the ASCVD score or the FRAC score, things like that, you're looking at those details from a database to calculate the risk. Those are not really applicable. So, for instance, this part of the questionnaire deals with temporal splitting, where you use past data to predict the chance of a future event happening, like the occurrence of a fracture in someone who's elderly. So these models usually have to use data from multiple time periods in the past. Again, that is not applicable because it's a prospective study and analysis. Second thing, if you're using past data, there has to be geographical splitting of the data set so that it's generalizable to a large population. Again, in this population, the study is done in the same geographical area where the model was developed also. So that is again a limitation of the study. Again, if how the predictors handled in the analysis, whether they have been, whether any categories have been merged together. This is again applicable when you're using a data set from a previous database, which is not applicable here. Describe any heterogeneity in the model parameter values and model performance. So this was a single large cohort study. They have not described how they quantified heterogeneity across hospitals or across countries. This was across UK, Ireland, and Wales. So they have not specified any heterogeneity across the geographical areas. And they have also not done a cluster analysis based on each hospital where it was done. Whether there was any variation in between the 13 hospitals where it was analyzed, that is also not mentioned in the study. Now, to specify the output of the prediction model, we have already covered this. This is the output algorithm they have followed. Now, some prediction models give you a percentage saying percentage chance of developing this outcome. Some use a risk stratification model where you classify them into low, medium, intermediate, and high risk. So here, this study, they have gone with the risk stratification model. And this is the algorithm they have followed to stratify the patients. Now, in addition to this, so in this particular study, we have talked about this capsule endoscope test, where they withdraw the cells, they centrifuge them, and then these cells are then analyzed by a pathologist. Now, they have also additionally here, they have deployed an AI algorithm to analyze the pathology slides and to reduce the time and the burden on the pathologist. They deployed an AI algorithm to pick up the P53 biomarkers. So it's a relatively simple AI algorithm that just looks at the color difference between the cells. If it picks up a color difference, it notifies the pathologist that this is positive. If there's no color difference, it notifies the pathologist that this is negative. So if you look at A, this is a columnar gland which are stained for P53. That all those brown cells are stained for P53. Now that AI algorithm, if it detects more than 4 cells clustered together, it says this is positive for P53. If you look at picture B, there are only 2 or 3 cells clustered together. That the AI algorithm will classify that as equivalent for P53, and that the pathologist would have to double check that. Again, C and D, there are larger clusters. So whatever is circled in green, the AI algorithm will say it as positive for P53. This one circle in blue, the algorithm would call it equivalent for P53, which would require confirmation by a pathologist. Now, if you look at E and F, these are actually cellular artifacts which are appearing brown. So the AI algorithm was not very efficient at picking up cellular artifacts. Even when there were artifacts like this, it mistakenly picked them up as positive for P53. So there are a lot of false positives for the AI, but it was good at identifying the true negatives. So there are few false negatives, but there are many false positives with this AI algorithm. So the graph you see here, all the so the graph you see there, all the entire shaded area that is shaded in red, that was indicated by the AI algorithm as actual true negatives. So if the AI algorithm said it was negative, there was no pathologist counter checking that. So if the AI said it was negative, it was not reviewed secondly by a pathologist at all. If the AI said it was positive or it was equivocal, then a pathologist would counter check it and confirm that it was true positive. So out of all the AI positives, only a few were actually confirmed as positive. The rest were then confirmed by the pathologist as negative. Another limitation of the study is that the use of this AI algorithm is not being mentioned in the original study protocol that is registered with the UK database. So that protocol is registered in 2018 before they started the study. In that, they have not mentioned that they're going to use this. They have not given any details of this. They have only said we will employ pathologists to identify the cells. So my interpretation is that this study was done from 2020 during the COVID period. I assume they had difficulty in continuing the study at that time. Most likely to reduce its time, they had changed the protocol and used this algorithm. But again, it's a limitation that they have not pre-specified this in the trial protocol. So the output was that the patient clinicians were educated about this new biomarker stratification tool, and they were informed about the results of the capsule endoscopy. Follow-up endoscopy was done within 24 months for all patients. The timing of the follow-up endoscopy was partly clinician decision driven. If they were high risk, then the clinician would expedite the endoscopy. And it was partly because of the prolonged waiting time given the NHS system. So this prediction model was developed and validated in the same subset in the UK. The training cohort included participants from 22 hospitals. The list of those hospitals are provided in the best 3 trial. The validation cohort, which is this particular study we are looking at, was patients recruited from 13 hospitals. There was no overlap of hospitals, but it was largely from the same geographic area. And the outcome and eligibility criteria remain consistent across the previous and the current study. Ethical approval. The study obtained ethical approval from the England Cambridge Central Research Ethics Committee. All participants provided informed written consent, and the study used de-identified data for each participant. Regarding whether it was uploaded to open source, so the study received funding only from the NHS. There was no other external source of funding. There was no funding from the manufacturer of the capsule endoscopy also. The funder had no role in the study design, conduct, or data analysis or publication. The study authors have not declared any conflict of interest. Ideally, they should have uploaded the disclosure forms to be viewed, but that has not been provided in the study. The study was prospectively registered. They have provided the trial registry number. ISRCT is the UK's clinical trial registry, and they have provided the number. Again, when I looked at the study protocol, I found that they have not mentioned the use of this AI tool to screen for pathology slides. Again, the study does not mention whether it was registered in the open science framework or not. The availability of data. So the patient's baseline clinical characteristics were taken from when they came for review, the baseline characteristics were taken from the NHS database. The study authors have not provided us with the individual data sets. Now, generally for a risk stratification tool also, ideally there should be some feedback from the patients and the participants who are going to benefit from this. Usually there should be asked for feedback about the effectiveness of the capsule endoscopy, whether they're comfortable with it. This particular trial does not mention any specific details about patient and public involvement. They have obtained a comprehensive informed consent from all participants. So the participants were probably aware of the objectives, the type of data collected, but they have not mentioned whether there was direct involvement in designing the study or in making the protocol also. So coming to before we go to the results, the validity of the study, the main limitation here is the methodology is different from the study protocol. We don't have any information about this AI algorithm, and the outcome assessors were not blinded to the prediction results. Coming to the results, so now ideally, because this is a prospective trial conducted over a 4-year period, there should be a flow diagram mentioning so many patients were recruited at the beginning, how many patients actually had the capsule endoscopy, how many patients came for the follow-up endoscopy, how much missing data was there, and what did they do about the missing data, which has not been provided. They're not mentioned missing data. They have not given us a flow diagram of how many patients came through. At the final results, they have said that 910 participants were recruited, and in the final results, they have provided us the data for 910 participants. But it's unlikely that all 910 actually followed through with the capsule endoscopy, followed through for the 4-year period. So there was probably missing data, but we don't have any information on how the authors dealt with it. So the baseline characteristics of the study population, a total of 910 participants were recruited. Based on only the clinical characteristics, they were classified into low risk or moderate risk. Generally males or more than females. And the length of the Barrett's esophagus segment, significant circumferential length or the longitudinal length was higher in only 11 patients. These were stratified into the moderate risk group. The overall histopathology, 90% of them had non-dysplastic Barrett's, and the remaining 10% had either low-grade dysplasia, high-grade dysplasia, and a few patients had carcinoma at follow-up. Coming to the results of the capsule endoscopy trial. So we talked about before they were recruited, they had to have a previous endoscopy done. So the time from the first endoscopy, which confirmed the Barrett's, to the time to the capsule sponge endoscopy was approximately 35 months for the low risk, which is around 3 years, and about 2 years for the moderate risk group, and about 2 to 3 years for the high risk group. So this is the time to the capsule endoscopy. Then from the capsule endoscopy to the second formal endoscopy, which would confirm the results of the capsule endoscopy, that was around 13 months for the low risk group and only 1 month for the high risk group. This again because the treating physician was informed about the capsule results, so they prioritized endoscopies for the high risk group. no significant age or gender differences. The important outcome that we want to look at here is the final histopathology. Now, this tool is to be deployed as a screening tool to ideally identify patients at low risk, avoid unnecessary endoscopies in the low risk group. So we are more interested in the low risk group. How many patients, based on this capsule endoscopy, out of those who were classified as low risk, how many of them actually went on to develop dysplasia, how many went on to develop cancer? So out of the low risk group, 98% at follow-up had only non-dysplastic Barrett's. 2% did have dysplasia, out of which 1% had a crypt dysplasia, which is a form of low grade. 8 were classified as low grade, and only 2 patients or less than 1% were classified as high grade dysplasia. And there were no patients in the low risk group who had adenocarcinoma. Now, in the high risk group, 60% of the patients who were called high risk actually had non-dysplastic Barrett's, and about 4% of them went on to develop adenocarcinoma. 17% and 16% developed low grade and high grade dysplasia, respectively. Now, again, because we are considering the use of this as a screening tool, the negative predictive value of patient in the low risk of the low risk category is around 97% for predicting a diagnosis of dysplasia. And the negative predictive value of a diagnosis of high grade dysplasia was around 99.6%. So it seems to have a high negative predictive value if a patient is classified in the low risk group. This is again a graphical representation of what we have talked about in the previous slide. So the first column represents the clinical group where patients are classified based on the clinical characteristics into low risk and high risk. Now, then you assess them with a capsule endoscopy for the biomarker status. Based on the biomarker status, 84% of them were biomarker negative, and 12% had other biomarkers positive, 3% had P53 positivity. Now, combining the clinical and the biomarker status, you get the third column, which is the combined results of the capsule sponge and clinical risk group. There we have, based on these two, we have classified them into low, intermediate, and high risk. 53% of patients in the low risk, 31% in intermediate, and 15% of patients in the high risk. Now, out of this low risk group, like we saw in the previous chart, a few patients, around 2% of them ended up being the intermediate, ended up having dysplasia at the final endoscopy. Sorry, just to tell you the expansions, HGD is high-grade dysplasia, IMC is intramucosal carcinoma, OAC is esophageal adenocarcinoma, LGD is low-grade dysplasia, IND is indeterminate dysplasia, and NDB is non-dysplastic Barrett's esophagus. So out of the low risk group, a few patients ended up having high-grade dysplasia and crypt dysplasia, whereas in the high risk group, 64% of patients had no dysplasia at the follow-up endoscopy. Now they have given us in the second bar graph, they have given us the individual breakdown of patients in the low risk group. So out of the so in the first column, out of 560 patients who were classified as low risk based on the clinical characteristics alone, in that group, we had 3 patients with esophageal adenocarcinoma, 2 patients with intramucosal carcinoma, and about 7 patients with high grade, 17% with low grade. Now, following the results of the capsule endoscopy, that classification, that groups are changed into low, moderate, and high risk. Now, at the end of the capsule endoscopy, in the low risk group, there were no patients with carcinoma. There was 2 patients with high grade dysplasia, 8 patients with low grade, and 1 patient with crypt dysplasia. So it does seem to confer a benefit as opposed to just clinical risk stratification alone. Now, that same data that we saw in the previous graph, again in the form of a tabular column. So based on the clinical risk stratification, 560 patients, out of 560, 30 patients went on to develop any form of dysplasia. In the second box that I've highlighted, based on the capsule and clinical risk stratification, in the low risk group, out of 489 patients, 11 patients or 2.2% of patients went on to develop dysplasia. Again, for we're looking at specifically high-grade dysplasia, in the low risk group, out of 489 patients, only 2 patients went on to develop high-grade dysplasia, which is about 0.4%. Now, we talked about the time interval to doing the follow-up endoscopy. So this is a graphical representation of the time it took after the capsule endoscopy, the time taken to do the follow-up endoscopy. So for the pink lines are the high risk tier 1 and 2. So those patients, they had a follow-up endoscopy at the most done within 3 months of the results of the capsule endoscopy. The green lines represent the low risk and the moderate risk groups. These patients had a significant delay in the follow-up endoscopy, and they took almost 24 months to 36 months to complete the endoscopy done. So again, do the results report any heterogeneity in model performance across the hospitals where the study was conducted? They have not done a subgroup analysis based on each hospital. Ideally, that would have helped us see if it is operator dependent or if the performance varies across the hospitals. We don't have that subgroup analysis. Lastly, the interpretation of the results. So the object of this study was to look at a capsule-based endoscopy with risk stratification tool. So 15% of patients in the high-risk group went on to develop dysplasia, and 2.2% of patients in the low-risk group went on to develop dysplasia, which seems to be quite low numbers. So overall, I would say that capsule endoscopy offers a less invasive way to triage patients and prioritize patients for endoscopy. So the limitations of the study was that predominantly this was done in UK, predominantly a wide cohort of patients. The limitations here were that there was a treatment bias as the physicians were informed about the capsule biopsy results before the formal endoscopy. There was a delay in the endoscopy up to 2 years in performing the endoscopy. The follow-up period was quite short. They have not subsequently followed up the patient for repeat endoscopies to see if the outcome of dysplasia varies further. Remember the previous BOSS trial that we talked about, they followed a patient for a median of 12.5 years, up to 15 years for some patients. This is quite a short follow-up period. And all the pathology slides were not reviewed by a pathologist. So they have deployed an AI algorithm and they're not counter-checked that with the pathologist. They are not explained about missing data. And the study protocol does not mention the use of this AI tool. So coming back to our clinical scenario, which is Mr. A who is not willing for repeat endoscopies. If the facilities were available, I would advise this patient to undergo capsule-based endoscopies because it seems to have a high negative predictive value and the overall risk of Barrett's esophagus progressing to adenocarcinoma is quite low.